Beginning with the next chapter of hematology, and that is the white blood cells. As always, you know that we are going to start off first with our basics and then we'll go on to the different diseases that you have to know. So the first thing that I'll start off with is what is happening in the bone marrow from day one. So before you have all those mature cells like neutrophils, lymphocytes and so on, the story always started from a stem cell. So first what you have is a pluripotent stem cell, and this is what all of you call as CD34 positive. I'll be telling you all the CD markers in a while. From a pluripotent stem cell comes the next thing, and that is a multipotent stem cell. That's the next thing to take its origin, the multipotent stem cell. And now from here, we are going to have two different, you can say, set of things which will help you do the entire chapter so swiftly. This is my favorite part because if you get this correct, the entire chapter is a cakewalk. From this arises something known as a common myeloid progenitor. Common myeloid progenitor. So this is going to give rise to all the myeloid lineage. And then similarly, there is something known as a common lymphoid progenitor. Common lymphoid progenitor. So let's take up the easier word because we always like to do easier things first. What do you think the common lymphoid progenitor is going to give rise to? Obviously, all the lymphocytes. So what are the lymphocytes that we know of? We know the T lymphocytes, we know the B lymphocytes and the natural killer lymphocytes. So the T cells, the B cells and the NK cells come from lymphoid progenitor, and I realize that this lymphoid progenitor has made its life so easy. Decided my name as lymphoid, I will only give rise to the lymphocytes. Then who gives rise to everything else? Lymphocytes are not the only WBCs. You have neutrophils, eosinophils, monocytes, basophils. Not only WBCs. Where are RBCs coming from? Where are megakaryocytes, platelets coming from? Imagine all of that load has been put on the common myeloid progenitor. So don't we all have, we've been through those days in college and school where we were all given a group work to do, but all the work used to be done by one or two people in the group and everyone else used to kind of chill and relax. That is what has happened over here. Ideally, the bone marrow wanted that the work should be divided between these two progenitors, but the lymphoid progenitor said, I'm taking the easy work and I'm only making lymphocytes. Rest, everything else the myeloid progenitor is making. So now remember, the myeloid progenitor gives rise to colony forming unit. CFU stands for colony forming unit, that is GM. And then there is a colony forming unit, that is ME. What do I mean by GM and ME? G stands for granulocytes, G stands for granulocytes, and M stands for monocytes. Similarly, when I write colony forming unit ME, so you will say, okay, WBCs are done, but what about platelets? What about megakaryocytes? So CFU-ME, M stands for megakaryocytes, M stands for megakaryocytes, and E stands for what? E stands for the erythroid lineage, means the red blood cells. So finally I have my list complete. Not so, I'm going to complete it further. What is there in the monocytes? Common sense, monocytes. But what is there in the granulocytes? This includes the neutrophils, the eosinophils and the basophils, or very commonly students also learn it as NBE. NBE, which is your governing body. So that is the one that is doing your exam for you. So now we have granulocytes are NBE. Neutrophil, basophils and eosinophils have granules. The other one is monocytes, which does not have granules, and lymphocytes have been taken care of by the lymphoid progenitor. So all your WBCs are sorted. After that, your megakaryocytes and RBCs are also sorted because the ME wala gives rise to M for megakaryocyte and E for erythroid. If you are clear with this, I can now move forward and explain to you some markers. For that, I will have to start from the beginning. Do you know that your pluripotent stem cell is CD34 positive? A very, very important question that you get in the paper. It is CD34 positive. After that, you would obviously want to know all of these. So I'm going to make a table for all of you so that life becomes a little simpler. Let's start off with the lymphoid cells. What all lymphoid cells do you have? T lymphocytes, B lymphocytes and NK cells. Remember, T lymphocyte is 1, 2, 8, 28. How easy to remember? 1, 2, 8, 28. CD 1, 2, 3, 4, 5, 6, 7, 8 and 28. So T is 1, 2, 8, 28. B cells are 1 in every lineage. So 10s, 20s, 40s. So 10s means it is CD10. 20s means starting from 19, 20, 21, 22, 23 and also going to be CD40. So simple, 10s, 20s, 40s, keep doubling. NK cells, there is no mnemonic needed. It is 16 and 56. That is the natural killer cell. So yes, to kill, natural killer means he has a natural bodybuilder's wala body. So he has a 16-inch bicep and something which is unachievable, a 56-inch chest, which was quite a famous joke also that went around, right? So 16 and 56, that is what you need for being a tough person, bodybuilder, natural killer cell. This is going to be all the lymphocytes. So now if I go back to my table, the lymphoid journey is over for me. I can come back to the others. So what are going to be there in the granulocytes, the monocytes, the megakaryocytes and the erythroid? Let's go ahead with it. So when they talk about in general about myeloid cells, and when I'm talking about myeloid cells, I am talking about the granulocytes. Remember, it's an easy way of learning. So myeloid, don't you think myelo should be the name of the stain? It is myeloperoxidase positive, common sense. Other than that, 1, 3, 3, 3. So that is CD13 and 33 is going to be positive in the myeloid cell. So it is simple. It is 1, 3, 3, 3, that is CD13 and 33. Moving on to the next. When we have monocytoid lineage, when I have monocytes, it is going to be CD11C, CD14 and CD64 positive. When I have megakaryocytes, they are going to be CD41, CD42 and CD61 positive. When I have erythroid lineage, erythroid is going to be CD71. If you feel that I am being very mean to you and randomly writing numbers and I'm not going to help you, no, I'm not that mean. I am going to help you. So first and foremost, I have already helped you with the lymphoid lineage. For T, B and NK, I have made you learn the story, right? T is 1 to 8, 28, easy to learn. B was keep double, that is 10s and 20s and 40s. Natural killer, I told you the bodybuilding story, a 16-inch bicep and a 56-inch chest. So natural killer cells, sorted. For myeloid, I told you the easiest way to learn is myeloperoxidase, and after that you have to do 1, 3, 3, 3, that is 13 and 33. Beyond that, for mono is sounding like mono, single, and megakaryo is sounding something very mega, something very deadly. So what do I learn? Mono is single. Single means 1, 1. Single, 11. Single on 14th Feb also. That is Valentine's Day. So it is single, 1, 1, then single on 14th Feb also, and single till he dies. So single at the age of 64 also. So 1, 4, 6, 4, single on 1, 1, single on 14th of Feb, and single till you die. That is 64. So monocyte is forever single, unfortunately. When I talk about megakaryocyte, because it's sounding so deadly, I don't know how many of you have been PUBG fans at one point of time, but I hope you remember in PUBG there's a very famous gun called the 416 gun. Right? In PUBG, there's a 416 gun, which you guys must have, of course, been aware of. If you've not played PUBG, then this mnemonic might not be of use to you. But today you've learned one more thing. There's a gun called M416 gun. And gun is deadly. So megakaryocyte, which is sounding like very, very deadly, I have learnt it as 4161. So see, 4161. That's the M416 gun. 4161, 41, 61, and with 41 you will also learn its neighbor 42. So 4161, remember 41 and so 41 and then 61, 61. These are the megakaryocyte, the deadly PUBG gun wala. Coming to the last one, erythroid. Now erythroid, don't you know erythroid has something called transferrin? So erythroid has something called transferrin receptor. The way you write transferrin, that is going to tell you a lot of things. How do you write T? You write T like this. So now make a number out of it. T is looking like a 7 and a 1. T is looking like a 7 and a 1. So this can look like a 7 and this is looking like a 1. So transferrin receptor is a CD71. That's the best way of doing this table. Let's do a recap. So for myeloid, you had myeloperoxidase and CD13 and 33, 1333. For mono, forever single. So this means 1 and 1, single, single on 14th of February, Valentine's Day also, and single till he dies, that is 64 also. Megakaryocyte is PUBG. So M4161. So 41 and 61 and 42 are the markers. For erythroid, it is going to be the transferrin receptor. On that note, you are done with your first part and all your markers are sorted. Quickly repeating, lymphoid progenitor only took care of lymphocytes and myeloid progenitor had to take care of everything else. Because now I'm starting with the story of myelopoiesis. Can you divide all the myeloid cells into the way I told you? I just told you that the lymphoid progenitor took care of lymphocytes. That's it, BTNK. Then all the other cells were divided either into a variety called granulocytes. So what all was there in granulocytes? Your NBE, neutrophil, basophil, eosinophil, all of that came in granulocytes. And then you had another variety which was not granular and that was monocytes. So ultimately, how many WBCs do we have? We have a total of 5 WBCs, but how are they forming? Because now I have to tell you formation, myelopoiesis. So please remember, it starts from something known as a myeloblast. The first story which is going to progress starts from myeloblast. So can I say myelo gives rise to all the granulocytes, myeloblast? Because you know what gives rise to monocytes? Monoblast is going to have a separate pathway to give rise to monocytes, and lymphoblast is going to have a separate pathway to give rise to lymphocytes. That's how simple it is. Most students skip this part and straight away jump to all those leukemias, lymphomas, and then the concept is never made. Please remember, when I say myeloblast, it is going to give rise to the NBE, that is the granulocytes. Monoblast will give rise to monocyte and lymphoblast will give rise to lymphocytes. Sorted? Let's move forward. Now, I am not interested in the detailing of these two. This I've learnt as it is. Monoblast will give rise to monocyte, lymphoblast will give rise to lymphocyte. Sorted. But this part of the story I want to concentrate on. How a myeloblast is giving rise to a granulocyte. So for that, you will all have to study one series of diagrams with me. First and foremost, like I told you, the first cell will be a myeloblast. And what is the methodology of understanding or remembering a myeloblast? A myeloblast is going to have OR rods. Myeloblast will have OR rods. In case you cannot visualize it, I'll show it to you like this. You can see an OR rod here. You can see another OR rod here. So this is what you call as that pinkish line. That's an OR rod and a myeloblast has it. After the myeloblast, now comes the pro of the members. The pro means the biggest cell. See, pro is always going to be the king of the jungle, right? So we have what we call as a promyelocyte. The next cell that is formed is a promyelocyte, and my identifying point is it is pro. It is the biggest cell that you have in this lineage. It's a pro. Coming to the next, cut out the pro. What are you left with? Just a myelocyte. So the next thing that is formed is just a myelocyte. And how have I seen it? So just cut out the pro. You have a myelocyte. How will you identify a myelocyte? Look at the shape of the nucleus. The shape of the nucleus is looking like a D. Draw it with me once again. The shape of the nucleus is looking like a D. So we call it a D-shaped nucleus. D-shaped nucleus. And remember, MD, imagine myelocyte already has what you guys are struggling for. You guys are struggling for that MD degree. God has given this lucky myelocyte the MD degree. Myelocyte has a D-shaped nucleus. After myelo, you are going to add a word in front of it and call it metamyelo. I call it as MM, metamyelocyte, MM. You know why do I call it as MM? Because now the shape of the nucleus is also going to look like an M. So that's such an easy way of learning. There is an indented nucleus. There is an indented nucleus. So I have learnt it that it looks something like an M, and that is why I'm calling it a metamyelocyte. Metamyelocyte is going to be M. Finally, that indentation becomes a little deep. Earlier it was just a tiny little dip. right? Now I say it has become a deeper indentation. What is it looking like? It's looking like a hairband. Like girls wear those hairbands, right? That's looking like a hairband. So we call it a band or a stab form. We call it a band or a stab form because you can see how like it's looking only like a band. And finally, what I have over here is a neutrophil. In this picture, I have a neutrophil, but what all could have been formed? NBE could be formed. Neutrophil could form, basophil could form, eosinophil could form, any of these things will form. So now you will ask me, how do you decide? You started your journey from myeloblast. How will this myeloblast know that later on I have to form neutrophil, basophil, eosinophil? So tell me one thing. When you go in first year, do you know whether you want to become a cardiothoracic surgeon or a neurosurgeon, or you want to be a gynecologist or a pathologist? No one knows. Starting mein to 1 or 2 years, no one knows. Gradually in your journey, you develop interest. By 4th year or internship, you get little bit clarity. So when did this cell get clarity that I have to make a neutrophil or a basophil or an eosinophil? So remember, what is the deciding time of your life? MD degree is the deciding time of your life. MD degree means when there is a myelocyte. So it is at this stage. It is at this stage that the decision, I call it the decision making. The decision making is done at a MD degree stage. Over here, it is decided that later on, is it going to become a neutrophil, eosinophil, or basophil? Easy to do. MD degree is your deciding time in life. So yes, let's do a very quick recap. The first cell always has to be a blast. How do I identify a myeloblast? By the OR rods. Then comes the pro, the king of the jungle, the biggest, the pro-myelocyte, biggest. Cut out the pro. What are you left with? Myelocyte. What is the shape of the myelocyte? D-shaped nucleus. Add a meta onto it. You get a metamyelocyte. Looks like meta-myelo. Looks like an M. Slight indentation. Now you're going to have a full indentation. It will start looking like a hairband. So you call it a hairband form. And finally, whatever you had thought in your MD time, you will make neutro, baso, or eo. So now they will ask you in the paper simply that please put this in the correct sequence. Either it will come as an image-based question or as a theory question. That finishes off your myelopoiesis. Let's see if you've been able to gather anything out of it. So if I ask you randomly, what is this cell? What is this cell? Look at the nucleus. What is it looking like? Is it looking like a D? No, it's not looking like a D. Is it looking like a complete hairband? Not even a complete hairband. It's a slight M kind of a thing, right? Slight indentation. What do you want to call it? It is a metamyelocyte. The M wala, the metamyelocyte. What is this? The next one. What cell is this? Again, what is the shape of the nucleus that you see over here? I can see a D, MD degree, God's gift. What is this God's gift? This is myelocyte. Myelocyte, God has gifted it with MD degree. Coming to the last one, what is this which is looking completely like a hairband? This obviously must be a band or a stab form because it's looking exactly like a hairband and there's no doubt about it. This is sorted for all of you, but again, going all the way back, this story was telling you only about how a myeloblast gave rise to all of this. Now, for the others, you don't have to know the story, but you at least need to know the pictures. How should I differentiate a myeloblast from a lymphoblast, and what are the stains for all of these three blasts that you should be knowing? So first, I'll tell you the differences between a myeloblast and a lymphoblast. So clearly, what you have written over here is a myeloblast. Over here, you have a lymphoblast, and I think you already know the methodology of distinguishing. You know that myeloblast is going to have these rods which we call as the OR rods. For that matter, they also ask you that OR rods are primarily composed of which kind of organelle. So remember, OR rods contain a lot of lysosomal enzymes and lysosomes. That could be an important question. So OR rods is going to have lysosomes. That's very, very important in many of your Q banks. You'll find this. So going back, so myeloblast is going to have an OR rod. Lymphoblast is not going to have an OR rod. Now comes their stains. So myeloblast, for common sense reason, is going to be positive for myeloperoxidase. No doubt about it. Other than that, Sudan black B and chloroacetate esterase. If you want to know the full form of this is known as chloroacetate esterase. So remember, we've done MPO, Sudan black B, and chloroacetate esterase for myeloblast. We will do a summary in the end. Just keep listening to me right now. Now we come to a lymphoblast. Does it have an OR rod? No, OR rod was a feature of myeloblast. Now there are not going to be any kind of OR rods that would be seen. There are no OR rods at all. What are the stains? You have two stains in front of you. One is a pink color pass, and it's a very important stain. You have to know this picture, mug it up by heart, because I know P for pass and P for pink. That concept I have since ages of pathology. But here the pink color has not gone to the entire cell. Here the pink color is in the form of these blocks. If you look at the pink color, it is forming these blocks. That is why we call it the very famous block positivity. Still, in some books you will mention it as dot blot positivity. It means the same. Whether they say block positivity or they say dot blot positivity, it is going to mean exactly the same. Got it? This was for all lymphoblasts, B lymphoblasts, T lymphoblasts, any lymphoblast. But if you are only and only interested in looking at T leukemias, T lymphoblasts, you will use a stain called acid phosphatase. Acid phosphatase is only for the T lymphoblasts, not for the B lymphoblasts. So what all have I studied up till now? Let's do a recap. Please note, myeloblast was positive for what? For myeloperoxidase, Sudan black B, and chloroacetate esterase. Lymphoblast is positive for what? Pass positivity shows you a block positivity, as you can see over here. And for the T lymphoblasts, you had acid phosphatase. The only blast that you're left with is a monoblast. They won't give you a picture, but at least they'll ask you the stain. And monoblast is NSE positive. What is NSE? NSE stands for non-specific esterase. Non-specific esterase. Now please note over here that when I was teaching you myeloblast, I told you something known as chloroacetate esterase. It was known as chloroacetate esterase. Means that was something specific. I gave you a name to it. The esterase was specific. It had a name. Here I'm not giving the esterase any name. I'm calling it non-specific esterase. So there'll always be a confusion which esterase is in which blast. So I have learnt it as monospecific esterase. Okay. So when you're writing monoblast, sometimes you all of you must be thinking, what does ma'am keep doing? She keeps changing the names. She keeps giving us mnemonics like forever single. But that is only because I myself during my journey have suffered so much because of not being able to mug up these things easily and giving it extra hours and wasting time in that process. So whenever I feel that something could come across as a confusion, help the students. Take out something from the name, give them a funny story, give them a correlation so that they don't have to waste and put in those many hours, and they can utilize that in solving questions rather than figuring out where was NSE and which was chloroacetate esterase. So remember, for monoblast, now you will all study it as monoblast. Okay, monoblast will tell you that it is the non-specific esterase that you have over here, whereas myeloblast becomes the chloroacetate esterase. Now, right now, these stains might be sounding way too much of information overload, but as you study the leukemias, this is going to be such a handy slide for all of you. On that note, let me ask for a test. What blasts are these? Myeloblast, lymphoblast, monoblast. Can you see something inside them? Can you see an OR rod here? Can you see an OR rod here? And I know for a fact there's no exception to it. If I have the presence of OR rods, which is made up of which organelle? Lysosomes. If I have OR rods, I am dealing with a myeloblast undoubtedly. So finally, I'm very happy because my entire story of the precursors is done. Precursors is done because now I'm ready to take on the journey and talk about these mature cells: neutrophil, basophil, eosinophil, monocyte, lymphocytes. Let's go into the mature world. This is the mature world that I want to tell you. And why is there suddenly a monkey coming out of it over here? Because first and foremost, I always write it as NLMEB. I will always write these as NLMEB, neutrophil, lymphocyte, monocyte, eosinophil, basophil. Why? Because we always say, never let monkeys eat bananas. Never let monkeys eat bananas. And that is how and why this cute little monkey and a banana is shown over here. So never let monkeys eat bananas tells you that never let monkey eat banana. Neutro, lympho, mono, eo, baso. Can you see? It's going from maximum to least. So you will have to learn their numbers, unfortunately. Yes. So let's start. But you have that in mind that I have to put it in a decreasing order. So maximum 2000 to 7000 cells are neutrophils. Then go a little less, somewhere around 2000, lower limit, 1000 to 3000 are lymphocytes. Then go less than 1000. I have learned less than 1000 is monocyte. Half kar do, less than 500 is eosinophil. And less than 100 is going to be basophil. Not at all difficult, trust me. Repeating, neutrophils are the maximum, 2000 to 7000. Then for lymphocytes, I have to go somewhere around 2000. So I go for 1000 to 3000. Then I'll go below 1000. Monocytes are less than 1000. Do it half. I say eosinophils are less than 500 and basophils are almost negligible, only 0 in the blood. So less than 100 is what I've taken. Now is it simple? You kind of keep going lower, lower, lower. So never let monkeys eat bananas are going to help you. So you've done the sequence, you've done the numbers, the absolute counts, but the identification still remains. So let's move forward and do this identification. So I'll tell you an identification point and I'll tell you maybe 1 or 2 diseases in which these cells comes, right? So again, and whenever this story comes up in front of me, never let monkeys eat bananas. That story remains alongside. So first and foremost, you have a neutrophil. The methodology of identifying a neutrophil is that you have to focus on the nuclear lobes, like you see 1, 2, 3 nuclear lobes over here. A neutrophil is going to show you 3 to 5 nuclear lobes. Neutrophil will be showing you 3 to 5 nuclear lobes. Where does a neutrophil increase? I think go back to your second chapter, inflammation. You all will agree with me that neutrophils are going to increase in all kind of acute inflammations, all kind of bacterial infections, and all of those neutrophils are going to increase. However, was there any exception in which neutrophils were not increasing? Remember typhoid. Typhoid was not showing neutrophils. It's an acute inflammation but no neutrophils. Typhoid shows you lymphocytes. So that is what I'm coming to next. How do you identify a lymphocyte? Please remember, it's the most innocent looking cell. It is a round cell with a round nucleus. There is no fancy shape, nothing fancy about it. It is a simple looking cell, and this is going to be associated with many of the viral infections. It is associated with which inflammation? It is associated with obviously chronic inflammation. But was there an exception of acute inflammation that I wanted to put up over here? I wanted to put up typhoid over here. That is where lymphocytes will come. In fact, another bacteria which is so prevalent in our country, and that is TB. You pick up a patient of TB and look at his blood test report, you will find TB is again chronic. TB usually tends to be chronic. So TB also tends to show you lymphocytes in the blood. Coming to the next, never let monkeys. So here we are on a story of a monocyte. How do I identify the monocyte? I have to look at the nucleus. There is what? There is a kidney-shaped nucleus. You can call it a kidney or you can call it reniform. If you want to sound more fancy, then call it a reniform nucleus. And what are the conditions in which the monocytes are going to come up? So remember, monocytes are going to be seen in M for M. Malaria cases, very, very important. Malaria cases are going to have monocytes. Other than that, there are some leukemias. In children, it is known as juvenile myelomonocytic leukemia. So it has the word mono, myelomonocytic leukemia. And in adults, chronic myelomonocytic leukemia. So again, the story is the same, myelomonocytic. So the word myelo is coming, myelomonocytic is coming. So mono word is coming, matlab monocytes are seen. Juvenile myelomonocytic leukemia, chronic myelomonocytic leukemia. Okay, coming to the next. But before that, this is from personal experience that I'm telling you. Whenever we have an outbreak of malaria, you have like thousands of samples roaming in your lab because everyone in your community is suffering from high fever, high grade fever with chills, and you want a malaria test for everyone. How do we pick out samples more probable for having malaria? By looking at the monocyte count of the counter. So whenever monocyte counts are more, I start thinking fever with chills with high monocytes, I start thinking of malaria first. Coming to the next, never let monkeys eat. Eat what? E for eosinophils. This is the most pretty looking cell of this entire series. It's most different. It's got a nice, pretty pinkish orange color. So the method of identifying is two. Number one, it is going to have orange-red granules. It is going to have orange-red granules, and that's not about it. Not only is it funky in terms of its color, it's very, very funky in terms of wearing headphones. Can you see the nucleus? It's got a bilobe nucleus which is looking like headphones. So I will call it bilobe nucleus, and after that, all the people can give it a terminology as per their name. Some people say it looks like a spectacle. Some people say it looks like a headphone. So I have learnt it that yeah, it's a funky looking cell, super funky. It's going to have a nice bright orange red color and it's going to be wearing headphones. Super funky cell. Where do you see it in not so funky diseases? You see it in two situations. Number one is allergy. So whenever someone has any allergy to the season change or allergic dermatitis, allergic conjunctivitis, allergic rhinitis, any allergy, most common, our country, bronchial asthma, any kind of allergy, eosinophils will be up. So you will suddenly see that whenever the season changes in the lab, everyone's eosinophils start getting elevated because it happens with season change and also with parasites. Parasitic infection. So they will always give you, there's a child who has hookworm infection, hookworm parasite, eosinophils will be more. Finally, coming to the last one, never let monkeys eat bananas, and that is the basophil. How do I identify basophil? BBB. Look at the color of the granules. The color of the granules are very, very blue-black granules. That is how I identify a basophil. These are said to be blue-black granules, and that one particular leukemia where you will find basophils is CML, and also basophils are seen in polycythemia vera. But CML, it's a part of the criteria. It is that important. So let's do a repeat. Never let monkeys eat bananas. 3 to 5 lobes. Lymphocyte, simple. Monocyte is going to be the kidney shaped. Then eosinophil is the funky looking orange cell with headphones on it. And basophil is BBB. It is going to have blue-black granules. Now, the question that came in the recent exam was, what is this cell? Never let monkeys eat bananas. What is this cell? Is it looking like a basophil to all of you? If yes, then you won the battle. If this is a basophil, they asked you what is the special stain of a basophil. And that same special stain is applicable to not only a basophil, but that same special stain is applicable to a mast cell also. That was a recent NEET PG question, and the answer to that is toluidine blue. The answer to that is toluidine blue. So what you see over here, you'll say, but ma'am, I don't know how many of you put your too much of mind into it, or do you usually not put logic while studying path? But toluidine blue sounds like blue, and I don't see anything blue here. The cell is looking purple to me. If you have your colors intact, you remember and you can see that I'm not seeing anything blue. I'm seeing something purple. So this is a two-faced stain. Yeah, I call it two-faced. Why? It has a different color, but it's showing a different color. So if I give you a bottle of toluidine blue, it will look blue in color. But when you look at it under the microscope, it's not looking blue, it's looking purple in color. What are these kind of stains known as? These are known as the metachromatic stain. These are known as the metachromatic stain. So I've written it also in two colors, means it has a different color. It's like that topper of your class who says, no, I have not studied anything. I've not even opened my textbook. I don't even know what the syllabus is. But next day when the Viva starts, he's giving maximum answers. He's taking maximum continuation sheets in the paper. So totally two-faced. Na? Same way, that is a metachromatic stain. It's showing a different color than what it is. It's blue in color, but it's showing a purple color over here. That is a metachromatic stain. Always remember that two-faced topper of your class. On that note, we are done with these main cells, but yes, you'll have to give a test. Randomly, you are supposed to tell me which of these belongs to which category. What cell is this? It looks the most different. That's why I picked it up. It's the pretty pink cell. The pretty pink cell makes it what? With the headphones, it makes it an eosinophil. But if I pick up this one, the one with blue, black and very bad looking, blue, black, bad looking is going to be basophil. This is everyone's favorite cell. There's no doubt about it. Lots of lobes. That's a neutrophil. This is what? Simple, no fancy appearance, nothing complicated, simple cell, lymphocyte. And finally, the cell which has a kidney in it, that is going to be a monocyte. So this is sorted. But what is that thing? I know your mind is going towards the upper left corner where you can see this cell. Let me give you options. Is this a myeloblast? No. Is this a myelocyte? D-shaped nucleus? No. Is it a metamyelocyte? M-shaped? No. Is it looking like a band? Is it looking something like a hairband? Yes. So this was actually a band form that was circulating over here. This was actually a band form that was circulating over here. So see, now you've got a hang of what every cell looks like. Somewhere you are sorted with your normal, because we can start with the diseases. Now when I'll start with the diseases of the white blood cells, first, I will like to tell you a little bit about the non-tumorous ones. I don't want to straight away jump on to, the leukemias, lymphomas. First, I'll tell you the non-neoplastic ones, and then we are going to proceed towards the neoplastic ones like leukemias, lymphoma. Non-neoplastic ones are not too many, but a quick mention about these you have to know. The first one that I have over here is a hypersegmented neutrophil. Now, right now I told you that the normal neutrophil has what? The normal neutrophil has 3 to 5 lobes. The normal neutrophil has 3 to 5 lobes. But when we say hypersegmented, means it is going to have 5 or more than 5 lobes in the cells. Let's count. 1, 2, 3, 4, 5, 6, 7. I have 7 lobes. Is this hypersegmented? Yes. And which is the anemia which I have already taught you in the red blood cell chapter? Megaloblastic anemia shows you hypersegmented. Normal was 3 to 5. So anything above that is hyper, but if anything is below that, if there are less than 3 means what? Basically means 2 only. Less than 3 is 2 now. So can you see these neutrophils which have just 2 nuclei? So can I call them hyposegmented, basically less than 3 lobes, or you can say 2 lobes in simpler words? That is hyposegmented, and this is referred to as the Pelger-Hewitt anomaly. This is known as the Pelger-Hewitt anomaly. However, please remember that Pelger-Hewitt anomaly is usually seen because of underlying some or the other genetical problem. If it is seen as a supplementary problem in some other disease, like primary disease of the patient is CML, chronic myeloid leukemia, but he is also showing you Pelger-Hewitt cells. Primary disease is MDS, myelodysplastic syndrome, but he is also showing you Pelger-Hewitt cells. Then in that situation, you call it a pseudo-Pelger-Hewitt anomaly. Repeating once again, Pelger-Hewitt anomaly is a genetic condition. And when you see it because of some other conditions as a secondary finding, you will call that as a pseudo-Pelger-Hewitt. Moving on to the next, which is a very famous disease called May-Heglin anomaly. Firstly, what is the genetic? May-Heglin, MYH. May-Heglin anomaly is MYH9 gene defect. Easiest to learn because the name speaks volumes. MYH, May-Heglin, and now look at what all is it going to have. For that, I will take up the Heglin out of it. I will take up the glin out of it, because the first G over here is going to tell me giant platelets. There are huge platelets, and how do I know that? See, look at this. What is this cell? Red color cell must be red blood cell, right? I know that a red blood cell is 7 microns. This much information you know from your RBC chapter. Red blood cell is 7 microns. Platelet is roughly half. Platelet should be 3.5, 4 microns. Basically, RBC ka adha. RBC's half is going to be a platelet. But over here, I see the platelet is almost looking similar to RBC. So it's definitely almost the size of an RBC it has reached. It had to be less than half. It's almost reached the size of the RBC, means this is going to be this is definitely a giant platelet. So the first G over here stands for giant platelet. Not only that, there is L. L means there is a low platelet count. There is thrombocytopenia, low platelet count. And finally, in means what? In refers to the inclusions. In refers to inclusions. There are inclusions in the granulocytes, and let me show you that inclusion. What granulocyte is this? Yes, what is the neutrophil? Very good. And if it is a neutrophil, can everyone appreciate there is an inclusion in the neutrophil? And this inclusion is known as the Dole body-like inclusion. So now obviously if I've added a word here, your mind is asking you, what is a Dole body? I'll come to that. Are you clear with May-Heglin first? May-Heglin means MYH. That is the genetic mutation. And from Heglin word, you are getting what all? So simply write it as May-Heglin in the paper, and this is gonna give you all the information. So the G will stand for giant platelets, the L will stand for low platelet count, and the IN will stand for inclusions, Dole body-like inclusions, because your next question towards me is, what is a Dole body? What exactly is it? That was Dole body-like inclusion, but what is a Dole body? Dole body is going to be seen in patients suffering from very severe infection, sepsis. So, when I get a blood sample in my lab and I'm seeing the sample and I start seeing these inclusions, I immediately call the clinician and ask, is this patient in sepsis? Is he showing you signs and symptoms of sepsis? Because Dole bodies are seen there. But the question that comes is, what is the composition, or which organelle is the Dole body made up of? So it is made up of dilated endoplasmic reticulum. It is made up of dilated endoplasmic reticulum, and there is no rocket science behind it. The way you write Dole bodies answers everything. Remember, Dole bodies are made up of dilated endoplasmic reticulum, the first alphabet and the last alphabet. So remember, it is made up of D for dilated and E for endoplasmic reticulum. Are we sorted? Dole bodies, you'll always remember the composition. It's a PYQ, very, very, very important. Dilated endoplasmic reticulum. So yes, having done with the Dole bodies, now let's move on to something that you've already studied it way back in your inflammation chapter. Do you remember we studied a disease called Shediac-Higashi disease? Do you remember what was the problem in it? Shediac-Higashi disease was a lysosomal problem. It was a List gene defect. And over there, I had given you a quick mnemonic about what all Shediac-Higashi has. Shediac had a mnemonic called Shediac, which we had studied, which we will quickly revise in less than 1 minute. What was C? C was for CNS alterations, neurological problems. H and E was for hemorrhage. The D and I was for decreased immunity. D and I was for decreased immunity. A was for albinism. The child had silvery gray hair. And finally, the K had coarse cytoplasmic granules. Coarse cytoplasmic granules, and that is why I have got you this picture over here. Now you identify a neutrophil very well. It has these lobes. It's a neutrophil, and you can see these thick granules that are present. That is the coarse granules that you see in Shediac-Higashi. Always remember the mnemonic Shediac. It's a lysosomal problem. Shediac will remind you that the K was for coarse granules. There's one more disease which shows you, the last one that I would want to discuss with you. One more disease which shows you the same is Alder-Riley anomaly. Remember, Alder-Riley anomaly also, if you see, shows you lots and lots of granules in it. There are large cytoplasmic granules that are noted. Remember, Alder-Riley anomaly is usually associated with a lot of mucopolysaccharidosis and lysosomal storage disorders. That is the association of Alder-Riley. That also shows you large granules. With which we have wrapped up the first part, and that is the non-neoplastic variety of the WBC disorders. Having discussed all of this, we are now going to start off with the neoplastic